in this, Neisseria can cause quite commonly, and Pseudomonas is another very dangerous cause of corneal ulcer, infectious corneal ulcer. So that's what I've depicted in the slides. But all the bacteria, bacilli and cocci that I mentioned in the previous slides was about infection occurring on the cornea in a cornea that is compromised. But here, these are the 4 very important organisms that can invade an intact cornea. The word intact here has a lot of meaning, because even if the cornea is intact, totally devoid of any aberrations or any predisposing factors, the organism can still go and affect the cornea, which makes it very dangerous. So what are these organisms? Neisseria meningitidis, specifically meningitidis. Then you can have Corynebacterium diphtheriae, Haemophilus influenza, Listeria monocytogenes. These are the most dangerous organisms because they can invade an intact corneal epithelium. But the predisposing factors that I mentioned was, which need not be present in these patients, is a corneal aberration due to any cause, trauma or eye rubbing or nail injury, etc. They can lead to epithelial drying. Dryness will alter the metabolic activity and causes necrosis of the epithelium. This is followed by desquamation. All this is a cascade, followed by desquamation of epithelial cells, and finally there's an epithelial damage, and this can result in a epithelial defect. When an epithelial defect gets infected, we call it corneal ulcer or infectious keratitis. So this is the very simple scheme of events that take place before a corneal ulcer occurs. So here I have just depicted for you a corneal ulcer which has been stained with fluorescent. The green color that you're seeing is typically a fluorescent stained ulcer. So this is only to show you that whenever we examine a patient with corneal ulcer, it is very important for us to talk about the size of the ulcer, the shape of the ulcer, the location of the ulcer. All other details I will be explaining to you further in my further slides, but this slide is only to show you that these are the 3 most important determining steps in diagnosis. So this, as you can see, is a large ulcer. It's almost about 9 millimeters in size, 9 to 10 millimeters in size, and it is invading the entire cornea. The central area is totally, the pupil is totally obscured. We can't see any of the underlying structures. So it means that the visual axis has been totally blocked. So when the visual axis is blocked, the visual potential is it's almost nil. And location of the ulcer, it is centrally placed. Another important point here is it is a fluorescent stained ulcer. A 2% fluorescent stain has been used, and the ulcer is stained. That is why we get this greenish color. So this is just a very gross description. This slide is a very gross description of what an ulcer is, how it looks like, and when you stain it, what is the further details you can see. So before we stain with fluorescent, when we examine the patient, it is very important for us to do what we call a corneal ulcer drawing. And this corneal ulcer drawing should be done in 2 views. One view is the diffuse view. Okay, so where you suppose you see a corneal ulcer here. If this is a corneal ulcer, you're just drawing the corneal ulcer and you're showing that, okay, so this patient has a cornea which is devoid of any abrasion, any infection in the periphery, but the central area is filled with necrotic tissue, and this is the corneal ulcer. Now, this is the diffuse view, but we also need to draw a slit view. So in my slit view, if this is a central pupillary area, in my slit view, I'm going to show that the ulcer has, the necrosis is seen like this. So if this is the slit, and then this is the iris, this is the lens. So this is just to show you that you need to draw 2 views. So when I see this view, I know that the visual axis is blocked, the ulcer is centrally placed, but this is very important. The side view is very important to see the depth. The depth cannot be assessed by the diffuse view, anterior posterior view, but it can be assessed by this. We need to know how deep it is, whether it's invading only the epithelium, whether it has gone to the stroma or it has gone to the Descemet's membrane, because when it reaches the Descemet's membrane, it becomes, likely to threaten a perforation. So perforation of the cornea. Now again, just to recall, the cornea has epithelium, Bowman's membrane, stroma, endothelium, and you have the Descemet's. Now a new layer is added on, which is called Duas layer, which is a pre-Descemet's layer. So although we conventionally believe that there are 5 layers in the cornea, now it has been redesignated as 6 corneal layers. So basically we need to know what is the depth of this corneal invasion.